بسم الله الرحمن الرحيم. صباح الخير حضراتكم طيبين. محاضرة على الديسلايبيديميا. Dyslipidemia lipids are non-polar organic compound characterized by insolubility in water. Lipids include triglyceride, phospholipid, and triglyceride formed of fatty acid and glycerol. We have different types of fatty acid. Saturated fatty acid, no double bond between carbon atom. Example, animal fat, palm oil, and coconut oil. Monounsaturated fatty acid that contain one double bond only. Example, olive oil and canola oil. Polyunsaturated fatty acid that contain more than one double bond, like corn oil and sunflower oil. Lipids are insoluble in water. To pass in blood, it should be carried with protein to form what is known as lipoprotein. Lipoprotein contain core and cap. The cap differentiate it to atherogenic and anti-atherogenic. Atherogenic lipoprotein or ApoB containing lipoprotein like very low density lipoprotein, intermediate density lipoprotein, and low density lipoprotein. The anti-atherogenic or ApoA containing lipoprotein is HDL or high density lipoprotein cholesterol. LDL or low density lipoprotein cholesterol is termed as bad cholesterol or ApoB lipoprotein. It is bad because it is the marker for atherogenesis. The fate of low density lipoprotein cholesterol either to the foam cell to play an important role in the pathogenesis of atherosclerosis or return back to the liver to be excreted across the biliary tree. Here, the LDL receptor is the main player for taking LDL from the blood to the liver. The LDL pass in the circulation when it exceeds the level of normal will penetrate the endothelium when there is endothelial injury or endothelial pores. This LDL after penetration of the endothelium will become oxidized. The oxidized LDL will be engulfed by the macrophage to form what is known as the foam cell. The foam cell is the characteristic cell for atherosclerosis. The foam cell will migrate toward the surface endothelium to form what is known as fatty streaks. These fatty streaks will migrate toward the surface of the endothelium to form what is known as fibrous plaque. The plaque will stimulate, or lipid plaque, the plaque will stimulate proliferation of the smooth muscle fiber and collagen fiber to cover this plaque to form what is known as cap, fibrous cap. The fibrous cap will cover the plaque and protect the plaque from being ruptured. Till this point, the blood vessel is patent. and there is no injury or there is no obliteration of the blood vessel. The fibrous cap will be acted upon by the proteolytic enzyme, leading to digestion of this fibrous cap and the release of its content to the lumen of the blood vessel, occlusion of the lumen of the blood vessel, and acute stroke, either cerebrovascular, coronary, or peripheral arterial occlusion. HDL, high density lipoprotein cholesterol, or ApoA containing lipoprotein, or protective. It's responsible for reversed cholesterol transport of HDL. It takes excess cholesterol from the blood vessel to the liver to be excreted across the biliary tree, reversed cholesterol transport. The second one is antioxidant and anti-inflammatory, vasodilator, anti-thrombotic, and endothelial protection. These are the function of HDL. This is a very important question. Anti-atherogenic property of HDL. HDL has a normal value in male from 45 up to 50 milligram per deciliter. In female from 40 up to 45 milligram per deciliter. HDL, we have causes of low HDL which are dangerous, like smoking, obesity, very low fat diet, hypertriglyceridemia, drugs that cause insulin resistant like beta blocker, anabolic steroid, and androgen. To increase the level of HDL, which is protective, lifestyle modification like exercise, stop smoking, drugs, fibrate, and niacin. These are drugs that increase the level of HDL. Dyslipidemia. Dyslipidemia means abnormality in the level of lipid component, cholesterol, triglyceride, HDL, and LDL. The normal value of cholesterol 200 milligram per deciliter. The normal value of triglyceride 100 milligram and 50 per deciliter. A new classification of dyslipidemia. This is the etiological and descriptive classification. Etiological, we have primary or genetic or hereditary and secondary causes of dyslipidemia. Primary, we have descriptive and etiological. Like when I say polygenic hypercholesterolemia, you have multiple gene defect and increase in cholesterol, LDL, and so we have increase in the cardiovascular risk because cholesterol linked or LDL linked to atherosclerosis, polygenic hypercholesterolemia. The second one, familial hypercholesterolemia. Familial, we have positive family history. We have increase in the LDL due to defect in the LDL receptor in the liver. This type, we have marked increase in the level of LDL, total cholesterol, and increase in vascular risk. We have two types of familial hypercholesterolemia, either homozygous or heterozygous. Homozygous children develop symptomatic early or premature coronary atherosclerosis. Heterozygous, more common, premature coronary artery disease, also both homozygous and heterozygous. The third type, familial hypertriglyceridemia. increase in the triglyceride due to defect in lipoprotein lipase, which is responsible for cleavage of the triglyceride. In this type, mainly increase in the triglyceride with mild increase in the cardiovascular risk. Chylomicronemia, increase in the exogenous triglyceride due to decrease in the lipoprotein lipase activity. The most important problem in the triglyceride is pancreatitis. Lastly, we have mixed combined cholesterol and triglyceride due to increase in the ApoB production and increase in the cardiovascular risk, because we have increase in the cholesterol, we have increase in the triglyceride, we have increase in the LDL, familial combined mixed dyslipidemia. The secondary causes of dyslipidemia, we have diabetic dyslipidemia, obesity, insulin resistant, metabolic syndrome. These are due to insulin resistant. Hypothyroidism, because lipoprotein lipase is the hormone sensitive lipase, depend on thyroxine in its activity and insulin. Nephrotic syndrome, an important cause, the deficiency of albumin. So there is no link between albumin and lipid. Nephrotic syndrome. Cholestatic jaundice due to defect in the excretion of cholesterol and triglyceride by the liver. Steroid and non-selective beta blocker drugs that causing insulin resistant, leading to secondary dyslipidemia. Using characteristic dyslipidemia. This figure, insulin resistant, leading to increase in the level of free fatty acid. This free fatty acid will burden the liver, leading to excessive accumulation or synthesis of triglyceride by the liver. These triglycerides leading to increase the synthesis of very low density lipoprotein cholesterol. This very low density lipoprotein cholesterol with excess triglyceride in it, leading to a transfer of triglyceride from very low density to low density by CETP, cholesterol ester transfer protein enzyme. This LDL contain excess triglyceride will be acted upon by lipoprotein lipase to remove triglyceride. So we have LDL containing cholesterol only, so small dense LDL, which is more atherogenic. This is the first characteristic of diabetic dyslipidemia. Increase in the triglyceride, increase in the small dense LDL and very low density lipoprotein cholesterol. On the other hand, this very low density lipoprotein cholesterol containing excess triglyceride will give, there will be transfer of triglyceride to HDL by CETP, cholesterol ester transfer protein. This HDL containing excess triglyceride will be removed from HDL. So we have nascent HDL without triglyceride, low molecular weight HDL, which will be excreted by the kidney. So the net result, we have characteristic dyslipidemia, increase in the triglyceride, increase in the very low density lipoprotein cholesterol, small dense LDL, excess ApoB, decrease HDL and ApoA. This is the atherogenic dyslipidemia of type 2 diabetes, insulin resistant, metabolic syndrome, and so on. Diagnostic approach of dyslipidemia. No patient complaining of dyslipidemia. Dyslipidemia, usually the patient coming by the sequelae, by the complication of dyslipidemia. So, should take proper history about the medication, especially drugs causing dyslipidemia, drugs used in the treatment of dyslipidemia, family history of cardiovascular disease, especially premature coronary, cerebral or peripheral, diabetes, hypertension, hypothyroidism, obstructive jaundice, and so on. History. Examination focus on densomas, ARCUS, blood pressure measurement, API, and waist densoma. Densoma means cholesterol deposition. We have different types of densoma. The first is the densilasma, cholesterol deposition. Planar densoma, cholesterol deposition on the interdigital area, the buttock. Tendon on the extensor acid, densoma in the pressure area. And lastly, eruptive on the skin, like neurofibromatosis and urticarial skin lesion. Densoma. Densoma is a pathognomonic for dyslipidemia. ARCUS. ARCUS, we have cholesterol deposition around the armpit. We have ARCUS senilis and ARCUS juvenilis. ARCUS senilis, this is normal. ARCUS juvenilis or premature ARCUS senilis signify dyslipidemia. Blood pressure measurement. Patients with dyslipidemia usually have hypertension, waist circumference, central obesity. Waist circumference in male exceed 94 cm, in female 80 cm. And this is a way to measure diagnosis depend on clinical presentation and investigation. Investigation you do, investigation for dyslipidemia, cholesterol, triglyceride, HDL and LDL. Investigation for the cause of dyslipidemia like diabetes, hypothyroidism, nephrotic syndrome, obstructive jaundice, and so on. Investigation for the sequelae of dyslipidemia like coronary, cerebral, and peripheral arterial disease. Treatment, we have guideline recommendation. We have ACC, American Association of Clinical Endocrine of dyslipidemia, divide the patient according to the risk category. We have 4 risk group. The first is the extreme risk, patient with progressive atherosclerotic cardiovascular disease, like unstable angina, despite reaching LDL goal 70 mg. Established clinical cardiovascular disease in patients with diabetes or CKD or heart failure. History of premature atherosclerotic cardiovascular disease. These are extreme risk. The LDL goal should be less than 55 mg per deciliter. Non-H 80 mg. ApoB 70 mg per deciliter. Extreme risk. Very high risk. Patient with established or recent hospitalization for acute coronary syndrome, peripheral or carotid arterial disease, diabetes or CKD alone, heart failure alone. Very high risk, LDL 70, non-HDL 100, ApoB 80 mg per deciliter. High risk. High risk patient more than 2 risk factors like hypertension, male 6, obesity, dyslipidemia. High risk. Diabetes or CKD, stage 3 to 4. LDL goal 100, non-HDL 130, ApoB 90. These are the risk category according to the ACC, American Association of Clinical. Treatment goal. Total cholesterol 200 mg. LDL according to the risk category. Low risk 130, moderate risk 100, high risk 100, very high 70, extreme 55. Non-HDL 30 mg above LDL, triglyceride 150, ApoB 90, high risk, very high 80, extreme risk 70. How to treat? Prescribe statin to the highest recommended dose or the highest tolerable dose. In case of statin intolerance, we have to add or to replace statin by ezetimibe or bile acid sequestra. If the goal not reached with the maximum tolerated dose of statin, we have to combine statin with bile acid resin or ezetimibe. In patients at very high risk or persisting elevation of LDL, despite treatment with the maximum tolerated dose of statin, we have to combine statin with PCSK9 inhibitor. PCSK9 inhibitor are the first and the only injectable or parenteral therapy for treatment of dyslipidemia. These drugs act by upregulation of LDL receptor on the liver. These drugs inhibit the breakdown of LDL receptor inside the liver by PCSK9. So these drugs increasing the level of LDL receptor. From these drugs we have Eviclumab. This drug taken parenteral, either weekly or twice or every 2 weeks. Prescribe statin to the highest recommended dose or the highest tolerable dose. In case of statin intolerance, replace statin by ezetimibe. In case of the goal not reached, combination of statin with ezetimibe or PCSK9 inhibitor. For the triglyceride should be a part of routine lipid screening. Triglyceride normal level 150 mg. Start treatment of triglyceride if they are exceed 50 mg. Very high risk equivalent to the extreme risk. High risk for the very high, moderate for the high, and this is the guideline. Very high risk, moderate. The recommendation. Treatment. The first line of treatment, therapeutic lifestyle intervention. Therapeutic lifestyle including stop smoking, weight loss, improvement of the diet, increase physical. Stop smoking. Advise all patients not to smoke. Smoking increase the level of LDL and the level of HDL. Weight loss. Moderate weight loss. 7% of the total body weight loss. Exercise. Saturated fat, polyunsaturated and monounsaturated fat less than 7%, polyunsaturated 10%, monounsaturated encourage up to 12%. Low cholesterol 2 mg. Minimize intake of trans fat because they are atherogenic. Increase plant sterol. Trans fat. Hydrogenation. Result of hydrogenation transform fat from polyunsaturated إلى unsaturated. Physical activity. Increase physical activity 150 mg per week. either 3 times or 5 times per week. Start gradually. Benefit of the exercise: increase insulin sensitivity, increase lipid HDL, decrease LDL, decrease blood pressure, decrease weight, decrease blood sugar, reduce the cardiovascular risk, prevent or delay the onset of type 2, give the sense of well-being. Benefit of exercise. Used. Statin. Statin are the drug of choice for treatment of hypercholesterolemia. Statin act by inhibition of HMG-CoA reductase enzyme, which is the rate-limiting enzyme for cholesterol synthesis. It lowers LDL cholesterol. Statin are the drug of choice for LDL. Statin, according to the intensity, we have high intensity, reduce LDL by more than 50%. Atorvastatin 40 mg, rosuvastatin 20 mg. Moderate intensity statin, LDL reduction from 30 up to 50 mg. We have atorvastatin 20 mg, rosuvastatin 10 mg, simvastatin 20 to 40, pravastatin 80, lovastatin, fluvastatin, and bevastatin. Low density statin therapy, LDL less than 30%. We have Simva, Prava, Luva, Fluva, and Viva. Usually we use in the treatment either high intensity statin or moderate intensity statin. Other value of statin. Atropic effect of the statin: increase the level of HDL, decrease ApoB, decrease C effect of statin. Also it has endothelial protection, anticoagulant, stabilization of the plaque, anti-inflammatory, pleiotropic effect of statin, endothelial protection, anticoagulant, plaque stabilization. Side effect of the statin: elevation of the liver enzyme and muscle enzyme. So, patient takes statin should do follow-up for the liver and muscle. If the liver enzyme are normal, give statin. If they are triple normal, don't give statin. Between normal and triple normal, give and follow up every month. If the enzymes exceed triple normal, statin. Fibrate. Fibrate are the drug of choice for treatment of hypertriglyceridemia. They act by inhibition of triglyceride production by the liver. The side effect similar to statin, elevation of the muscle and liver. The third drug, bile acid resin. They act by replacement of the bile acid. So they inhibit the absorption of cholesterol and triglyceride because bile acid and bile salt are an important step in the absorption of cholesterol and triglyceride. Drug termed as cholestyramine, very expensive and cause flatulence and abdominal acid resin. The fourth drug, niacin or nicotinic acid, it prevents the conversion of very low density lipoprotein cholesterol to low density lipoprotein cholesterol. These drugs causing elevation of HDL. The drug, blood sugar, elevation of the blood sugar, flushing, reactivation of peptic ulcer, and maybe hepatotoxic. Ezetimibe, this drug, responsible for absorption of cholesterol from the ileum, inhibition of the intestinal absorption of cholesterol, inhibition of intestinal absorption of cholesterol through this. The last drug is PCSK9 inhibitor or alercumab or eviculumab. This drug, alercumab, only PCSK9 inhibitor, the only injectable drugs to be used in the treatment of dyslipidemia. Stimulation of LDL receptor increase the number of LDL receptor on the surface of the liver through inhibition of the uptake or the breakdown of these receptor by PCSK9 enzyme. These drugs taken parenteral, these drugs are expensive. The only indication in acute coronary syndrome patient despite of maximum tolerated dose of statin, familial hyperlipidemia, heterogeneous familial hyperdyslipidemia, intolerance. الدوز الاركيوماب 75 or 150 milligram subcutaneous every 2 weeks, targeting LDL level 25 up to 50 milligram and allowing the level to be reached to 15 milligram. Reduce MACE, myocardial infarction, ischemic stroke, and was associated with a lower rate of all mortality, alarcumab. Lastly, fish oil or omega-3 fatty acid is an adjuvant therapy. It's not a main therapy for treatment of dyslipidemia. Besides gastrointestinal disturbance. Combination therapy, statin and fibrate, has not been shown to improve atherosclerotic cardiovascular disease. Combination therapy with statin and niacin has not been shown to improve cardiovascular risk reduction. For the patient with fasting hypertriglyceridemia more than 50 mg and treatment of the secondary causes of hypertriglyceridemia to reduce the risk of pancreatitis, fibrate between 175 up to 499 we can give in. And lastly, I thank you for your attention.